Welcome, curious minds, to the deep dive.
Yeah.
Have you ever truly paused to marvel at the human body? Specifically, that intricate, tireless defense system we all carry around.
Mm-hmm.
The immune system.
Mm-hmm.
It's a silent, vigilant guardian, constantly battling an unseen world of threats, from insidious bacteria to relentless viruses. It's astounding when it operates flawlessly. A symphony of millions of specialized cells and proteins working in concert.
It truly is a masterpiece of biological engineering. I mean, this system is tasked with the incredibly complex job of distinguishing between self, everything that belongs to you, and non-self, which encompasses everything from a simple dust particle to a life-threatening pathogen.
Right.
And it performs this task with remarkable precision, hour after hour, day after day, all to keep us healthy.
And that core concept, the self versus non-self distinction, is where the trouble begins, isn't it?
Oh.
Because what happens when this complex, delicate system falters? Or perhaps even more remarkably, what about when medical science tries to introduce something unequivocally foreign into the body to save a life, like an organ transplant? Today, our deep dive is precisely about those two critical areas, immune disorders and transplant immunology.
We've taken a stack of fascinating sources, a detailed breakdown of these critical aspects of human immunology, and our mission, as always, is to unpack the most important nuggets of knowledge and insight for you.
Mm-hmm.
Think of this as your shortcut to becoming truly well-informed on a topic that not only touches so many lives directly, but also reveals the extraordinary, often precarious balance within our own biology.
Absolutely. This isn't just about memorizing complex medical terms or understanding cellular pathways. It's about appreciating the profound ingenuity of medical science when that delicate balance is disrupted, and, equally, the inherent vulnerabilities within our own bodies.
Exactly.
We're going to explore what goes wrong, why it goes wrong, and most importantly, what medical professionals are doing to intervene, to repair, or to strategically redirect these powerful biological forces. Let's really unpack this intricate dance of defense and disruption. So let's kick things off with a fundamental concept: immunodeficiency. We've all experienced a cold or a flu, and our bodies usually bounce back. But what does it really mean when we say the body's entire defense mechanism is impaired? What does that translate to for an individual?
Well, at its core, immunodeficiency means the host's defense mechanism is simply not functioning as it should. Imagine your body's immune system as a fortress, with guards, walls, and alarm systems.
Okay.
In immunodeficiency, some part of that fortress is critically compromised. What this practically looked like for an individual is often a relentless cycle of recurrent microbial infections.
Yeah.
Their body just can't fight off what it should normally be able to handle, whether it's a common bacterium or a more unusual pathogen.
And why does this matter so deeply to you, the listener? Think about how often you might get a common cold or recover effortlessly from a minor cut.
Mm-hmm.
For someone with an immunodeficiency, these common occurrences, which for us might be a minor inconvenience, can escalate into incredibly serious, even life-threatening challenges. Their body lacks the proper tools to mount an effective defense, turning everyday threats into monumental battles.
That's a crucial point. The range of severity is vast, but the common thread is a profound vulnerability. When we categorize these conditions, there's a crucial distinction based on their origin. We talk about two main types: primary and secondary immunodeficiency disorders.
Right.
This distinction tells us a lot about the root cause and often the approach to treatment.
Let's dive into that distinction. First, primary immunodeficiency disorders. These are the ones that are often present from birth, right? They're essentially foundational, sometimes genetic defects in the immune system's very blueprint.
Precisely. Primary immunodeficiencies, often abbreviated as PIDs, are intrinsic defects. They result from abnormalities in the immune system's development or function.
Okay.
And while the genetic defect is foundational, present from birth, clinical signs don't always appear immediately. They can sometimes manifest later in life, even into adulthood.
Ah, okay.
These defects can strike at any level, affecting the adaptive immune functions like B cells or T cells, or the more immediate innate functions such as the complement system or phagocytes. Understanding which part is broken is key to understanding the specific vulnerabilities.
And this is where it gets truly fascinating, because when you look at how defects in specific components of this incredibly complex system lead to vastly different problems, you start to appreciate the intricate design of our immunity.
Mm-hmm.
Let's start with B-cell immunodeficiencies, also known as humoral defects.
Yeah.
What's the core issue here, and why is it so critical?
The fundamental problem with B-cell immunodeficiencies lies primarily in defects in antibody production. Think of antibodies as the precision-guided missiles of your immune system, highly effective at neutralizing specific threats.
Right.
Since antibodies are absolutely key against extracellular bacteria, the kinds that cause pus-forming infections, patients with these conditions are very susceptible to pyogenic bacterial infections. They lack that crucial rapid response infantry, so to speak, to wall off and neutralize these invaders.
And we have some specific examples of these, which powerfully highlight just how precise these failures can be and how devastating that can be. For instance, X-linked hypogammaglobulinemia, or XLA.
XLA is a classic example, considered a pure B-cell deficiency. It's an X-linked trait, meaning it predominantly affects boys because they have only one X chromosome.
Okay.
What you see is very low or even completely absent levels of serum and secretory immunoglobulins, IgA, IgG, IgM. It stems from mutations in the Bruton's tyrosine kinase, or BAA gene.
BAA, right.
Yeah, this specific gene is crucial for B-cell differentiation and maturation. So without it, B-cells simply can't develop properly, leading to a profound lack of antibodies. Children with XLA face recurrent bacterial infections, particularly of the respiratory tract, ears, and sinuses, often requiring lifelong antibody replacement therapy.
Then there are selective immunoglobulin deficiencies. It sounds like you're missing just some of your antibodies, not all of them, which might make it harder to spot, I imagine.
That's accurate. In these cases, there's a deficiency of one or more specific antibody classes, such as IgA, IgM, or certain IgG subclasses, while other immunoglobulin levels remain normal. Selective IgA deficiency, for example, is remarkably common, affecting perhaps 1 in 600 people, yet many individuals with it remain largely asymptomatic.
I'll be that common.
Yeah. But for others, it significantly increases susceptibility to infections of the respiratory, gastrointestinal, and urogenital tracts, where IgA plays a crucial role as a frontline defense on mucosal surfaces. And interestingly, it's also observed more frequently in individuals with autoimmune diseases, hinting at a complex interplay between different immune dysregulations.
What about hyper-IgM syndrome? The name itself sounds a bit paradoxical, doesn't it, if we're talking about deficiencies?
It absolutely does, and it highlights a critical point in B-cell development. In hyper-IgM syndrome, you indeed see high serum IgM levels, but paradoxically, very low levels of IgG, IgA, and IgE.
Why is that?
It happens because B-cells can't switch from producing IgM, their initial antibody, to producing the other, more specialized antibody types. This inability to class switch is typically due to defects in T-cell help for B-cells or in the B-cells themselves.
I see.
This imbalance leads to recurrent microbial infections because they lack the specific high-affinity antibodies needed for a robust defense, and often it's also associated with frustratingly persistent autoimmune disorders.
And one more, transcobalamin II deficiency. This seems to link directly to metabolism, which underscores how interconnected our body's systems really are.
It does. This is an autosomal recessive disorder that beautifully, if tragically, illustrates the profound impact of nutrient deficiencies on immunity. It causes a severe vitamin B12 deficiency.
Right.
Vitamin B12 is essential for cell metabolism and DNA synthesis. When it's lacking due to this deficiency, it ripples through the body, leading to depleted plasma cells. These are the mature B cells that serve as the very factories producing our antibodies.
The antibody factories, yeah.
Exactly, and consequently, diminish immunoglobulin levels. It's a powerful reminder that our immune system relies on a complex web of metabolic processes to function properly.
So we've covered what happens when the immune system's antibody factories are compromised. But antibodies are just one part of this complex defense. What about the other crucial architects of our immunity? The T cells. Let's talk about T-cell immunodeficiencies or cellular defects. If B cells are the precision missile launchers, what role do T cells play, and what kind of vulnerabilities arise when their function falters?
Well, T cells are indeed the orchestrators, the strategists, and the direct combatants of the immune system. They are critical for fighting intracellular pathogens like viruses, fungi, and protozoa, and for coordinating other immune responses.
Okay.
So when T cell function is affected, patients become highly susceptible to those particular types of infections, especially opportunistic infections that a healthy immune system would typically just brush aside.
When we talk about T-cell deficiencies, some conditions immediately strike you with their profound impact. What's a key example that truly illustrates the devastation when T-cell maturation is compromised, like thymicroplasia, also known as DiGeorge syndrome?
DeGeorge syndrome is a stark example. It's a congenital defect resulting from abnormal development of the third and fourth pharyngeal pouches during fetal development.
Right in the embryo.
Exactly. This leads to the thymus, the specialized organ where T cells mature and learn to distinguish self from non-self, being hypoplastic or underdeveloped or even completely absent. The severe T cell deficiency makes patients incredibly vulnerable to viral, fungal, and protozoal infections, and it can also profoundly affect the parathyroid glands, leading to calcium imbalances. It shows how a defect in a single developmental step can cascade into widespread immune system failure.
And for something more specific, chronic mucocutaneous candidiasis.
That's a fascinating and often frustrating example of a specific T cell response deficiency. It's an inherited disorder where the T cells have a specific inability to mount an effective immune response against Candida fungi, which is a very common yeast. This makes individuals prone to persistent, recurrent, and often disfiguring fungal infections of the skin, nails, and mucous membranes, which are incredibly difficult to clear.
And finally, purine nucleoside phosphorylase, or PNP deficiency. This enzyme deficiency sounds like a biochemical roadblock.
It is essentially a biochemical roadblock. Think of enzymes as tiny essential workers in our cells, facilitating crucial chemical reactions.
Right.
When PNP is deficient, it leads to the accumulation of a substance called adenosine and its metabolic byproducts. This buildup then interferes directly with the cell's ability to build DNA, essentially jamming the machinery that T cells, and to a lesser extent B cells, need to replicate and function properly.
Okay.
The result is a critical impairment in both arms of our adaptive immunity, leading to severe immunodeficiency.
Now, what if both B and T cells are affected? That sounds like a double whammy indeed. These are the combined B cell and T cell deficiencies.
You're right. It's truly a double whammy, impacting both humoral antibody-mediated and cell-mediated, T cell-mediated immunity. This leads to profound, severe, and broad susceptibility to a wide range of pathogens. These are often the most devastating forms of immunodeficiency.
And the most well-known and tragically impactful example of this is severe combined immunodeficiency, or SCID, often heartbreakingly called bubble boy disease.
Yes, SCID is the most severe form of primary immunodeficiency. Infants with SCID have a gross functional impairment of both humoral and cell-mediated immunity. Their immune systems are so compromised that they are extremely susceptible to fungal, bacterial, and viral infections from birth. Even attenuated vaccines, which use weakened live pathogens and are normally safe for healthy children, can be dangerous for these infants because their immune system cannot handle even the weakened form.
Right.
Without aggressive treatment, such as bone marrow transplantation, survival beyond 1 year is extremely rare, highlighting the absolute necessity of a functioning adaptive immune system.
That's just heartbreaking. What about Wiskott-Aldrich syndrome, or WAS? This condition always struck me as unique due to its triad of symptoms.
WAS is an X-linked recessive immunodeficiency characterized by a very specific triad of symptoms. Severe eczema, which is a chronic inflammatory skin condition, thrombocytopenia, which is a dangerously low platelet count leading to bleeding issues, and increased susceptibility to infection.
A specific triad, yeah.
It involves impaired cell-mediated immunity and a specific inability to respond to polysaccharide antigens, which are found on the surfaces of many bacteria, leaving patients vulnerable to recurrent bacterial infections.
Ataxia-telangiectasia. This one sounds like it connects the immune system with neurological issues.
It does, which illustrates the far-reaching effects of genetic defects. This is an autosomal recessive disease caused by mutations in DNA repair enzymes, specifically the ATM gene.
DNA repair.
Yes. It's characterized by progressive neurological issues, primarily ataxia or poor muscle coordination and balance, which worsens over time. There are also dilated blood vessels, called telangiectasias, often visible in the eyes and on the skin. Immunologically, patients suffer from recurrent infections and often have IgA and IgE deficiency, demonstrating a combined immunodeficiency.
Then there's Nezeloff syndrome.
Nezeloff syndrome is characterized by a marked T-cell immunity deficiency, alongside varying degrees of B-cell immunity deficiency, leading to broadly impaired adaptive immunity. This combination often results in symptoms like chronic diarrhea and a heightened susceptibility to persistent viral and fungal infections.
And an interesting one, MH class II deficiency. This brings us back to those crucial recognition molecules you mentioned earlier.
It does. This is an autosomal recessive disease where antigen-presenting cells, or APCs, the cells responsible for showing foreign particles to T cells, fail to express MHC class II molecules.
So the T cells can't see the problem.
Exactly. Since CD4 helper T cells, which are crucial for coordinating both cellular and humoral immunity, can only recognize antigens presented on MHC class II, this leads to a profound CD4 T cell deficiency.
Right.
The result is not only impaired T cell function, but also deficient antibody production, as B cells often require CD4 help to fully activate and produce effective antibodies.
We've talked about B cells, T cells, and combined deficiencies. But the immune system has other components too, like the complement system. What happens when that sophisticated backup system fails?
The complement system is an intricate cascade of proteins that essentially complements the actions of antibodies and phagocytes. It acts like a chain reaction, leading to pathogen destruction and inflammation.
What?
Genetic deficiencies in these components can lead to increased susceptibility to specific types of infections or even cause immune complex diseases. For example, a C3 deficiency is particularly severe, leading to recurrent pyogenic bacterial infections, because C3 is central to both the classical and alternative pathways of complement activation.
So C3 is like a linchpin.
It really is.
Yeah.
Conversely, deficiencies in C5 through C8 specifically enhance susceptibility to Neisseria bacteremia, because these components are essential for forming the membrane attack complex, which directly lyses certain bacteria like Neisseria.
So it's like a crucial part of the immediate response and cleanup crew that's suddenly down. And then there are phagocyte deficiencies, affecting the very cells designed to engulf and destroy pathogens.
Exactly. These affect the fundamental function of phagocytic cells, like neutrophils and macrophages. These cells are the frontline soldiers that literally engulf and digest invading pathogens. When they're impaired, pathogens can multiply unchecked.
A specific example here is leukocyte adhesion deficiency, or LAD.
LAD is an autosomal recessive disease caused by mutations in integrin genes. Integrins are crucial adhesion molecules, essentially sticky proteins on the surface of immune cells that allow them to stick and roll along blood vessel walls and then migrate into infected tissues.
Like Velcro for cells.
Sort of, yeah. So this mutation causes poor adhesion of neutrophils to endothelial surfaces, the lining of blood vessels, leading to inadequate phagocytosis and severe recurrent bacterial infections, as the neutrophils simply can't get to where the fight is happening.
And cyclic neutropenia.
This is an autosomal dominant disease characterized by periodic, severe fluctuations in neutrophil counts. Every 21 days or so, patients experience a dramatic drop in their neutrophil numbers to very low levels, which typically lasts for 3 to 6 days.
That's incredibly specific.
It is. During these periods, patients are highly susceptible to life-threatening bacterial infections and often suffer from symptoms like fever, mouth ulcers, and skin infections.
Wow, so that's the extensive landscape of primary immunodeficiencies, all stemming from something going wrong in the immune system's very development or core machinery. But then we have secondary immunodeficiency disorders, which are acquired. These are significantly more common, aren't they?
Much, much more common, yeah. These are not inherited genetic defects, but rather immune system impairments that result from other underlying diseases, certain medical treatments, or external environmental factors. They represent a loss of previously normal immune function due to external triggers rather than a congenital defect in the immune system's blueprint itself.
So what are some of the common culprits here? The triggers that cause these secondary deficiencies? What kind of external factors can truly compromise our body's defenses?
Well, a very significant and often overlooked one is malnutrition. When the body lacks essential nutrients, it can profoundly impact the immune system. For instance, protein energy malnutrition leads to reduced synthesis of critical immunoglobulins and complement proteins, which directly increases susceptibility to bacterial infections. Vitamins like A, C, D, and minerals like zinc are also absolutely vital for robust immune function, and deficiencies can lead to widespread immune suppression.
And certain infections themselves can also cause immunosuppression.
Yeah.
We hear about HIV/AIDS, of course, as the most profound example.
Yes, HIV is the quintessential example. The human immunodeficiency virus specifically infects and progressively destroys CD4 plus helper T cells, which are the command and control centers of the adaptive immune system.
The orchestrators we talked about.
Exactly. This leads to profound suppression of cell-mediated immunity, leaving individuals highly susceptible to opportunistic pathogens that would be harmless to a healthy person, as well as certain rare tumors. But beyond Beyond HIV, other infections can also cause temporary or more lasting immunosuppression. Measles, for instance, can cause temporary suppression of delayed hypersensitivity and altered T-cell function, making children vulnerable to secondary bacterial infections for weeks or even months after the initial illness.
Right.
Even cytomegalovirus, or CMV, a very common herpes virus, is known to cause immunosuppression, especially in transplant patients.
Malignancies also play a role, I imagine, especially those affecting the blood cells, the very building blocks of the immune system.
Correct. Lymphoproliferative diseases such as lymphomas, leukemias, and multiple myeloma directly arise from and affect immune cells or their precursors.
Okay.
These cancers can either diminish immune function by crowding out healthy immune cell production in the bone marrow, or by producing abnormal, non-functional immune cells, leading to a profound impairment of the body's defenses.
And then, perhaps ironically, a lot of medical therapy can actually suppress the immune system. It's a bit of a catch-22, isn't it? You're trying to treat one problem, but the treatment itself, perhaps through necessary drugs or procedures, opens the door to another vulnerability by inadvertently suppressing the immune system.
It absolutely is a tightrope walk. This includes a wide range of drugs designed to modulate immune responses. Immunosuppressants, for example, are vital in transplantation or autoimmune diseases. Cytotoxic drugs, like methotrexate and cyclophosphamide, commonly used in chemotherapy, work by inhibiting DNA and RNA synthesis, thereby suppressing the rapid cell division and differentiation of immune cells.
Okay.
Steroid therapy, like prednisone, is also a powerful anti-inflammatory and immunosuppressant. All of these can significantly diminish or even abolish immune function. Additionally, radiotherapy, widely used in cancer treatment, has a general depressive effect on all rapidly dividing cells, including immune cells, leading to secondary infections. And finally, surgical removal of the spleen, which is a critical immune organ for filtering blood and mounting responses against encapsulated bacteria, can also significantly diminish overall immune function.
You mentioned it earlier, but it feels counterintuitive. Autoimmune diseases, paradoxically, can also impair overall immunity. It seems like the body is both overreacting and underperforming.
It does seem counterintuitive, but it's a testament to the complex, interconnected nature of immune regulation. Conditions like rheumatoid arthritis and systemic lupus erythematosus, while being immune overreactions that attack self-tissue, can also paradoxically impair overall immune function. This can happen through chronic inflammation, exhausting immune resources, the destruction of immune cells by the autoimmune process itself, or through the very treatments used to suppress the autoimmune response, creating a vicious cycle of dysregulation.
And are there other broader conditions that can lead to secondary immunodeficiency, perhaps ones we encounter in everyday life?
Yes, certainly. Factors such as advanced aging, for instance, naturally leads to a phenomenon called immunosenescence, where the immune system becomes less robust. Severe burns cause immense physiological stress and compromise the skin barrier, leading to widespread immune suppression. Even prolonged psychological depression has been linked to altered immune function.
Really? Depression, too?
Yes. Chronic metabolic diseases like diabetes mellitus can impair neutrophil function and lead to poor wound healing, making infections more likely. And kidney failure can lead to uremia, which has a direct toxic effect on immune cells. All these conditions, though diverse, can create a fertile ground for opportunistic infections.
Okay, so that's a comprehensive look at what immunodeficiencies are and their myriad causes, both congenital and acquired. So, for a patient, how do doctors typically diagnose and manage these complex conditions? What are the key clues that something's fundamentally wrong with the body's shields?
Well, the suspicion of an immunodeficiency often arises from a constellation of clinical clues. We look for an unusual frequency or severity of infections, for example, a child constantly battling severe ear infections, or an adult suffering from pneumonia multiple times a year.
Okay.
We also pay close attention to infections with opportunistic microorganisms, those pathogens that typically wouldn't cause a problem in a healthy individual. And critically, infections that are simply difficult to eradicate with standard, appropriate antibiotics are a major red flag.
Right.
Recurrent pyogenic bacterial infections often point to a B-cell deficiency, indicating a problem with antibody production. Conversely, persistent or severe viral, protozoal, and fungal infections more strongly suggest a T-cell deficiency, highlighting a breakdown in cellular immunity.
So if someone's constantly battling these unusual or stubborn infections, that's a big red flag. What happens next once a suspicion is raised? What kind of diagnostic tools are at a doctor's disposal?
Diagnosis typically involves extensive and specialized blood work. This isn't just a routine blood count. We're looking at specific components of the immune system, quantifying different types of immune cells, measuring immunoglobulin levels, assessing complement activity, and performing functional assays to see if immune cells are behaving as they should. Genetic testing is often crucial for primary immunodeficiencies. For example, flow cytometry can identify specific lymphocyte subsets, like CD4 and CD8 T cells, while assays measuring antibody responses to vaccines can tell us if B cells are functioning properly.
Got it.
Once accurately identified, management aims to avoid repeated infections and improve quality of life. This includes targeted therapies such as administering intravenous gamma globulin or IVI for antibody deficiencies, essentially giving the patient the antibodies they can't produce.
Right, replacement therapy.
Exactly. Appropriate antimicrobial therapy, often prophylactic antibiotics, is also key. Patient education and counseling are vital to help them understand their condition and manage risks. For some severe primary deficiencies, especially SCID, bone marrow transplantation is an important and potentially curative option, offering a chance to rebuild a functional immune system from scratch.
That's a powerful transition because we've just talked about a system that's too weak or simply dysfunctional. Now let's move on to autoimmunity. This is where the body's immune system, its very own defense, actually attacks itself. It's a fundamental paradox, a betrayal from within.
It truly is a profound paradox.
No.
Autoimmunity is fundamentally a condition where the body's immune system, which is normally designed with incredible precision to distinguish between self and non-self components, erroneously attacks its own healthy tissues. This phenomenon was historically and aptly called horror autotoxicus by the pioneering immunologist Paul Ehrlich, who over a century ago recognized the immune system's inherent potential for injury to self if its self-tolerance mechanisms failed.
Horror autotoxicus.
Yeah, it's a critical concept. The immune system's power is a double-edged sword. Without proper regulation, that power can be turned inward.
Horror autotoxicus. What a dramatic yet fitting term. So, how does this betrayal happen? How does this sophisticated, finely tuned immune system get it so wrong?
Oh.
What's fascinating here is how many different and intricate ways the immune system can go awry, leading to self-attack.
Indeed, the pathways to autoimmunity are remarkably diverse. One key mechanism involves the release of sequestered or hidden antigens. Certain tissues within the body, like sperm, central nervous system components, and the lens and uveal system of the eye, are normally considered immunologically privileged.
Privileged? How so?
They are protected from direct exposure to the immune system during fetal development, meaning the body doesn't develop tolerance to them. If these antigens are suddenly released due to injury, say, lens protein after cataract surgery, or heart muscle antigens after a myocardial infarction, the immune system encounters them for the first time, recognizes them as foreign, and can launch an attack, causing damage to the very tissues they originated from.
Ah, okay. It's like opening a Pandora's box of self-antigens.
So it's about exposing something the immune system has never been trained on. What about antigen alteration, creating what are called neoantigens? This sounds like the body's own components are changing their identity.
Precisely. Existing tissue antigens can be altered by various external or internal factors. These include physical factors like irradiation, light exposure, or extreme cold, chemical factors like certain drugs such as procainamide, penicillin, or sulfonamides that can bind to proteins and alter them.
Right, like drugs changing them.
Exactly. Or biological factors like viral infections or bacterial enzymes that can modify host molecules. When these alterations occur, they create neoantigens, antigens that are no longer recognized as self by the immune system, effectively triggering an immune response against what was once a perfectly normal part of the body. It's like a disguise that tricks the immune system.
That's a complex interaction. And then there's something called epitope spreading. This implies a kind of domino effect, doesn't it? Yes, it's very much a domino effect, and it helps explain the chronic, progressive nature of many autoimmune diseases. Epitope spreading suggests that initial damage to cells, perhaps from a viral infection, or even an initial limited autoimmune attack, can expose previously hidden autoantigens or new epitopes on existing antigens.
Okay.
Once these new antigens are revealed, they can then stimulate autoreactive T cells that were not involved in the initial immune response. This broadens the immune attack to new targets, causing more widespread tissue damage and perpetuating the autoimmune disease.
So it just keeps getting worse.
It's a vicious cycle where the initial insult expands the targets for future attacks.
This next one, molecular mimicry. Sounds like an imposter syndrome within the body.
That's an excellent analogy. Molecular mimicry is a fascinating and clinically significant mechanism. It involves an infection by a microbial pathogen that possesses antigenic determinants, the specific parts the immune system recognizes that are structurally similar or even identical to normal host cell components.
Right.
The immune response initially mounted against the pathogen, then mistakenly cross-reacts with the host's own tissues because the immune cells can't tell the difference between the pathogen's mimicked antigen and the body's own similar molecule.
Do you have any real-world examples that illustrate this, where an infection could lead to a lasting autoimmune condition?
Absolutely. A classic and deeply impactful example is rheumatic fever. This autoimmune disease can develop after infection with Streptococcus pyogenes bacteria, commonly known as strep throat.
Strep throat, okay.
Antibodies generated against the bacterial M proteins cross-react with structurally similar proteins found in the heart, joints, and brain tissues, leading to severe inflammation and damage in those organs.
Wow.
Another historical, though fortunately much less common now, example involved older rabies vaccines that used sheep brain antigens. These could lead to neuroparalytic complications in humans due to cross-reaction with human neural tissues, a direct result of molecular mimicry. It shows how even efforts to protect can inadvertently trigger self-attack.
That's both fascinating and, frankly, terrifying. What about polyclonal B-cell activation? This sounds like a general alarm that leads to friendly fire.
It's precisely that. Normally, only very specific B-cell clones are activated by a particular antigen, leading to a targeted immune response. However, certain potent stimuli can non-specifically activate multiple B-cell clones, leading to a widespread, uncontrolled immune response. These stimuli can include certain chemicals, powerful bacterial products like lipopolysaccharide, LPS, specific enzymes, some antibiotics, or infections with certain bacteria like mycoplasma, or viruses such as Epstein-Barr virus, EBV, or cytomegalovirus, CMV.
A whole range of things.
Yeah. This widespread non-specific activation can lead to the production of a broad range of non-specific antibodies and critically also autoantibodies. We see this, for instance, in AIDS patients, where chronic HIV infection can lead to polyclonal B-cell activation and high levels of autoantibodies to their own red blood cells and platelets, causing secondary autoimmune issues.
So it's like a general alert that goes haywire and starts targeting friendlies. And what about the activity of helper and suppressor T cells? That sounds like a balance that's gone profoundly wrong in autoimmunity.
It is indeed a critical balance, and its disruption is central to many autoimmune conditions. Imbalances such as enhanced helper T-cell activity that overstimulates B cells and other immune cells, or, crucially, decreased suppressor T-cell function, have been strongly implicated in autoimmunity.
So T cells.
Regulatory T-cells, or TREGs, are a specific subset of T-cells that normally act as the immune system's peacekeepers. They actively suppress immune responses to prevent these anti-self reactions and maintain tolerance.
Okay.
So defects in their number or function, or an imbalance between various T-cell subsets, can profoundly impair cellular immune responses and significantly contribute to the development and persistence of autoimmunity. It's a breakdown in the system's self-policing mechanism.
And as with so many medical conditions, genetic factors also play a significant role. It seems some people are simply predisposed.
Indeed. Genetic predisposition is undeniably very important, influencing susceptibility to autoimmune diseases. Certain human leukocyte antigen, or HLA, genes are particularly strongly associated with an increased risk for specific autoimmune conditions.
HLA again.
Exactly. For instance, specific HLA alleles are known risk factors for type 1 diabetes or rheumatoid arthritis. The theory of clonal selection, for example, posits that self-reactive lymphocyte clones are normally eliminated during embryonic life, a process called negative selection to prevent autoimmunity. If these self-reactive clones persist due to genetic factors, or if new self-reactive clones develop later in life, perhaps due to somatic mutation, it could lead directly to autoimmune processes. It's often a combination of genetic susceptibility and environmental triggers that ultimately tips the balance.
So if someone suspects they might have an autoimmune disease, what are some of the typical characteristics that would point doctors in that direction? What's the pattern they look for, the telltale signs?
Well, autoimmune diseases typically exhibit several characteristic features that help guide diagnosis. Firstly, you often see elevated immunoglobulin levels in the blood, reflecting a hyperactive B-cell response.
Okay.
Crucially, there are demonstrable autoantibodies circulating in the patient's serum. The anti-nuclear antibody test, or ANA, for example, is one of the most common screening tests for systemic autoimmune diseases.
INA test, yeah.
Microscopic examination of affected tissues often reveals an accumulation of lymphocytes and plasma cells at the lesion sites, indicating an ongoing immune attack. Furthermore, a patient's response to treatment can be diagnostic. These conditions often show significant improvement from corticosteroids or other immunosuppressive therapy, which works by calming the overactive immune response.
Right.
Another characteristic is the occurrence of multiple autoimmune lesions in one individual. It's not uncommon for someone to have more than one autoimmune condition simultaneously, like rheumatoid arthritis and Sjogren's syndrome. Yeah. As we discussed, there's often a clear genetic predisposition and, notably, a higher incidence among females for many autoimmune conditions. Finally, their chronic and usually non-reversible nature means they require long-term management rather than a cure.
That gives you a clear picture of what doctors are looking for, a puzzle with many pieces. Now let's talk about the types and examples of autoimmune diseases. Are they all widespread, affecting the whole body, or can they be more localized?
They're broadly classified into two main types based on the scope of the immune attack: organ-specific and systemic.
Let's start with the organ-specific autoimmune diseases. These are the targeted attacks where the immune system zeroes in on a single organ, right?
Exactly. In these cases, the immune response is tightly focused, targeting antigens unique to a single organ or gland, and consequently, primarily affecting only that specific organ or tissue, even though the underlying immune dysregulation is systemic.
What are some vivid examples of this kind of targeted attack?
A prime example is Hashimoto's thyroiditis, where a cell-mediated reaction and autoantibodies, specifically anti-thyroglobulin and anti-thyroid peroxidase antibodies, progressively destroy the thyroid cells, leading to hypothyroidism and underactive thyroid.
Okay, underactive thyroid.
Then there's Graves' disease, which is also thyroid-related but acts in the opposite manner. Here, anti-self antibodies don't destroy the gland, but instead stimulate the thyroid gland's TSH receptors to produce excess thyroid hormones, resulting in hyperthyroidism, often accompanied by a goiter and characteristic bulging eyes.
So one attacks and disables, the other overstimulates. Fascinating.
It is.
What about myasthenia gravis? This one impacts muscle function.
In myasthenia gravis, autoantibodies specifically block or destroy the acetylcholine receptors at neuromuscular junctions. Acetylcholine is the neurotransmitter essential for transmitting signals from nerves to muscles, allowing for muscle contraction. When these receptors are blocked, it leads to progressive skeletal muscle weakness and fatigue, particularly noticeable with repetitive movements.
And a very well-known one, insulin-dependent diabetes mellitus, or type I diabetes.
That's a profoundly impactful autoimmune disease where specific T cells mistakenly identify and destroy the insulin-secreting beta cells in the pancreas. This destruction leads to an absolute lack of insulin production, which is vital for regulating blood sugar, thus necessitating lifelong insulin replacement therapy.
Right.
We also have Addison's disease, where autoimmune adrenalitis involves circulating antibodies against the adrenal cortex cells, leading to insufficient production of adrenal hormones like cortisol.
There are also conditions affecting blood cells, like autoimmune hemolytic anemia.
Yes, in this condition, autoantibodies target antigens on the surface of red blood cells, causing either complement-mediated lysis, directly bursting the cells, or promoting their destruction by macrophages, leading to anemia.
Right.
Similarly, pernicious anemia involves autoantibodies targeting gastric parietal cells, or intrinsic factor, which are crucial for vitamin B12 absorption in the gut. Without intrinsic factor, B12 cannot be absorbed, leading to a deficiency and a specific type of anemia.
So those are the focused organ-specific attacks. Then we have the systemic autoimmune diseases, where the damage is much more widespread, often affecting multiple systems throughout the body.
These are much broader and reflect a more generalized defect in immune regulation. The immune response in these conditions is directed against a wide range of common target antigens found across multiple organs and tissues. This reflects a fundamental failure of self-tolerance that isn't limited to a single organ.
The classic and often most complex example here is systemic lupus erythematosus, or SLE.
SLE, often just called lupus, is a chronic multi-system disease. It's characterized by the production of autoantibodies against an incredibly vast array of tissue antigens found in almost every cell, including DNA, histones, proteins associated with DNA, red blood cells, platelets, and leukocytes.
Wow, so basically everything.
Pretty much. This leads to widespread tissue damage affecting joints, skin, kidneys, brain, lungs, and blood vessels, manifesting with a remarkably diverse range of symptoms. It's truly a master of disguise in the world of diseases.
And rheumatoid arthritis, this is a very common one.
In rheumatoid arthritis, the immune system mistakenly attacks the lining of the joints, causing chronic inflammation. This involves the formation of IgG and IgM immune complexes, autoantibodies, often referred to as rheumatoid factors, which, along with complement activation, lead to severe damage to cartilage and bone joints, causing debilitating pain, stiffness, and progressive deformity.
What about Sjogren's syndrome?
Sjogren's syndrome involves autoantibodies primarily affecting the exocrine glands, particularly the salivary and lacrimal glands, leading to characteristic symptoms like dry mouth and dry eyes.
Right, the dryness.
Exactly. However, it can also affect other organs, with autoantibodies sometimes targeting the liver, kidney, and thyroid, making it a systemic condition with widespread potential impact.
And finally, multiple sclerosis. This is a neurological condition, but with an autoimmune root.
Exactly. Multiple sclerosis is a neurological condition where T cells and autoantibodies launch an attack against the myelin sheath, the protective fatty covering around nerve fibers in the brain and spinal cord. This demyelination disrupts nerve signals, leading to a wide variety of neurological symptoms, including numbness, weakness, vision problems, and issues with coordination and balance. It's a devastating example of the immune system attacking a critical part of the central nervous system.
That's quite a list of debilitating conditions, affecting nearly every part of the body. So, given these are cases where the body is attacking itself, how are autoimmune diseases typically treated? What are the strategies to calm an overreactive, misdirected immune system?
Well, treatment for autoimmune diseases is primarily aimed at suppressing the immune and/or inflammatory responses to halt or slow down the self-destruction. The cornerstone of therapy often involves immunosuppressants and corticosteroids.
Yeah, steroids.
Yeah. Corticosteroids, like prednisone, are powerful anti-inflammatory drugs that broadly suppress immune cell function. Immunosuppressants, such as methotrexate or azathioprine, act by inhibiting the proliferation and function of immune cells. More targeted biological therapies, like monoclonal antibodies that block specific cytokines or immune cell receptors, have also revolutionized treatment for many conditions, offering more precise suppression with fewer side effects.
And sometimes replacement is needed too?
Yes, in some cases, replacement therapy may also be necessary, such as insulin for type 1 diabetes or thyroid hormone for Hashimoto's. It's important to remember that suppression of the immune system, especially in extreme conditions, is a delicate balance.
Yeah.
While it's vital to protect the body from self-attack, it also leaves the body more vulnerable to infections, as the very defenses that were overactive are now deliberately dampened. Managing this trade-off is one of the greatest challenges in autoimmune disease treatment, often requiring lifelong monitoring and adjustment of therapies.
That's a perfect segue, because you just mentioned the challenges of suppressing the immune system to treat autoimmune diseases. Now let's talk about a situation where we want the immune system to quiet down or even to tolerate something it would naturally see as foreign. Transplant immunology. This is perhaps the ultimate challenge of introducing the other into the body, a life-saving yet inherently risky endeavor.
It is indeed a high-stakes game. The goal of transplantation is the transfer of cells, tissues, or entire organs, which we collectively call grafts or transplants, from a donor to a recipient. The success of this hinges absolutely on the recipient's immune response to the donor tissue. This raises an important question. How do we get the body to accept something that is genetically distinct, something that isn't self, without triggering its powerful innate defense mechanisms? It's a constant battle between saving a life and the body's fundamental drive for self-preservation.
It sounds like a high-stakes game of convincing the body not to attack. Let's start with the different types of transplants or grafts, classified by how genetically related the donor and recipient are. This spectrum tells us a lot about the immune challenge involved.
Right. The classifications range from perfectly matched to entirely foreign, each presenting a different immunological hurdle. The most ideal scenario from an immunological perspective is an autograft.
Autograft, okay.
This is the transfer of an individual's own tissue from one site to another within the same body. Think of skin grafts for severe burns, where a piece of healthy skin from one part of the body is moved to cover a damaged area, or bypass surgery using a segment of one's own blood vessels to create a new path for blood flow around a blocked artery. In these cases, immune rejection is minimal or completely absent. Because the tissue is genetically identical to the recipient, it is still self.
That makes perfect sense. It's the body's own material. What about a syngraft or isograft? This must be exceedingly rare in human medicine.
It is indeed rare. A syngraft is the transfer of tissue between genetically identical individuals, such as identical twins, or, in research, between highly inbred animal strains.
Identical twins, okay.
Here, too, rejection problems are minimal because the genetic match is virtually perfect. For humans, this is largely limited to identical twin donors and recipients.
And then the most common type, and the one that usually comes to mind when we talk about organ donation, is an allograft. This is where the real immunological battle begins, isn't it?
Absolutely. This is where the vast majority of organ transplantations fall. An allograft is the transfer of tissue or an organ between genetically different members of the same species. For example, from one human to another unrelated human, or even between close relatives who are not identical twins.
Right.
This is indeed the most common type of transplantation, and critically, it is subject to immune rejection because the tissues are genetically distinct and thus carry foreign self-markers.
And finally, a xenograft. This sounds like something out of science fiction, or perhaps the future of transplantation.
A xenograft involves the transfer of tissues or organs between members of different species, for instance, from an animal to a human. Think of pig heart valves used in human cardiac surgery, though those are typically a cellular grafts.
Right, just the valve structure.
Yeah, whole organ xenotransplantation, like attempting to transplant a pig heart into a human, is currently a cutting-edge field of research. These grafts are almost always immediately and violently rejected by an immunocompetent recipient due to vastly disparate genetic relationships and pre-existing natural antibodies. It represents the biggest immunological hurdle.
So with allografts being the most common and the primary focus of modern transplant medicine, let's really dig into allograft rejection. Why does the body say no to a potentially life-saving gift, despite our best efforts? What is the fundamental mechanism driving this rejection?
Well, allograft rejection is essentially a vigorous immune response mounted by the recipient against the transplanted tissue, viewing it as fundamentally foreign. This response is primarily mediated by T cells, which are incredibly sensitive to differences in major histocompatibility complex, or MHC molecules.
MHC, okay.
In humans, these MHC molecules are known as HLA, or human leukocyte antigens. These HLA molecules are like unique genetic fingerprints expressed on the surface of almost all our cells, signaling self. When recipients' T cells encounter donor cells displaying foreign HLA, they immediately detect the difference and perceive it as a threat.
How exactly do these T cells spot the difference between self and foreign HLA? Are there specific mechanisms of graft rejection that govern this recognition?
Yes, the recognition of foreign HLA on donor antigen-presenting cells, or APCs, by recipient T cells occurs primarily in two critical ways. The first is direct presentation.
Direct presentation.
Yeah. Imagine the donor organ arrives carrying its own APCs. Recipient T cells directly recognize these intact foreign MHC molecules displayed on the donor APCs within the graft. It involves a fascinating cross-reaction, where the recipient's T cell receptor, which is normally selected to recognize its own MHC molecules presenting a foreign peptide, instead recognizes the foreign MHC molecule itself as a foreign entity, even with its bound self peptide.
Huh.
It's a bit like a security guard trained to recognize a specific uniform with a particular badge, but who also recognizes that a completely different foreign uniform is inherently suspicious regardless of the badge it displays.
So it's almost like the T cell is saying, I recognize a key, but it's not quite my key, so it must be an intruder. That direct recognition sounds very potent. What's the second way?
The second way is indirect presentation. This is a more subtle but equally important pathway. In this scenario, the donor MHC molecules from the transplanted organ are shed or released. These foreign MHC molecules are then taken up, processed, and presented as small peptides by the recipient's own APCs, now displayed on their self-MHC molecules.
Ah. So the recipient cells show the foreign fragments.
Exactly. So instead of directly seeing the foreign MHC, the recipient's T cells are responding to the fragments of the foreign MHC being presented by their own cells. This pathway is particularly important for chronic rejection, acting as a slower, persistent recognition mechanism.
Once that recognition happens, whether direct or indirect, What are the stages of cell-mediated graft rejection? How does this immune attack unfold in a transplanted organ?
It unfolds in distinct phases. It begins with the sensitization phase. This is where recipient CD4 plus helper T cells and CD8 plus cytotoxic T cells recognize allogenins, the foreign antigens on the donor graft cells, and begin to proliferate rapidly.
Hey, big up.
Exactly. It's the initial activation and expansion of the recipient's immune forces in response to the donor MHC molecules and their associated peptide ligands. This phase typically occurs in the lymph nodes draining the graft. Following sensitization, we enter the effector stage, which is when the actual immune destruction of the graft occurs. This is primarily mediated by cell-mediated reactions. This includes delayed type hypersensitivity, DTH, a slower inflammatory response driven by activated macrophages and P cells, and crucially, cytotoxic T lymphocyte, CTL-mediated cytotoxicity, where activated CD8 plus T cells directly recognize and kill donor graft cells.
The killer T cells.
Yep. Macrophages are also heavily recruited to the site and contribute significantly to the inflammation and tissue damage. Less commonly, but still playing a role, are antibody plus complement lysis, where antibodies bind to donor cells and activate the complement cascade to destroy them, and antibody-dependent cell-mediated cytotoxicity, or ADCC, where antibodies tag donor cells for destruction by natural killer cells.
And this immune attack, does it always happen at the same speed, or is it classified by how quickly it manifests, indicating different underlying mechanisms and treatment approaches?
It's critically classified by its timing, which directly indicates different underlying mechanisms and guides clinical response. The most rapid and dramatic form is hyperacute rejection.
Hyperacute.
Sounds fast. It occurs extremely rapidly, within minutes to hours after transplantation, sometimes even while the surgeon is still in the operating room. It happens in recipients who already have pre-existing antibodies against the graft, often due to prior blood transfusions, previous transplants, or even pregnancies where they might have been exposed to foreign HLA.
Ah, pre-existing antibodies.
Exactly. It's characterized by massive intravascular platelet aggregates, widespread thrombosis, ischemia, and necrosis within the graft, leading to irreversible graft loss. Modern cross-matching techniques, which screen for these pre-existing antibodies, are designed specifically to prevent this catastrophic type of rejection.
So it's an immediate catastrophic failure, a complete no-go. What about acute rejection? This seems to be the one that transplant teams are most often managing.
Acute rejection is indeed the most common form that transplant teams actively manage. It typically develops days to weeks after transplantation, but can occur months later.
Okay.
This involves both cellular immune responses, primarily T cells and macrophages infiltrating the graft, and humoral immune responses, meaning new antibodies developing against the graft. This leads to inflammation and tissue damage within the transplanted organ, manifesting as a decline in organ function. Fortunately, with modern immunosuppressive drugs, acute rejection episodes are often reversible if caught and treated promptly, making vigilance and close monitoring crucial for transplant recipients.
And then the long-term, insidious issue, chronic rejection. This must be the ultimate challenge for long-term graft survival, something that quietly erodes the organ over time.
Chronic rejection is precisely that, an insidious, progressive loss of grafted organ function that occurs months or even many years after transplantation. It's a complex process involving both immune and non-immune mechanisms, making it much harder to pinpoint and treat. A common feature is chronic vascular endothelial injury, leading to fibrosis and occlusion of the blood vessels within the organ. This progressive scarring and narrowing of blood supply slowly chokes the organ, eventually leading to its failure. While immunosuppression helps, chronic rejection remains a significant long-term hurdle for most transplant recipients.
It sounds like the body is constantly trying to recognize whether something is self or foreign.
Yeah.
And a big part of that recognition, as you mentioned earlier, lies in something called histocompatibility antigens, or HLA.
Yeah.
Can you elaborate on why these are so critical to successful transplantation?
Absolutely. These polymorphic genes, primarily the major histocompatibility complex, or MHC, known as HLA in humans, are the key determinants of whether tissues are recognized as self or foreign.
The genetic fingerprint.
Exactly. They are incredibly diverse within the human population, which is why finding a perfect match between unrelated individuals is so challenging. Each person inherits a unique set of HLA genes from their parents, creating a distinct genetic fingerprint on their cells. HLA typing, where donor and recipient tissues are matched for as many HLA alleles as possible, is absolutely essential for donor-recipient matching. The better the HLA match, meaning the fewer differences in these crucial self-markers, the less intense the recipient's immune response will be, and the significantly lower the risk of rejection.
Makes sense.
It's why living-related donors often provide better outcomes as they share more HLA genes.
So understanding these intricate rejection mechanisms, how do medical professionals go about preventing graft rejection? How do we strategically trick the immune system into acceptance, or at least into tolerance?
Well, the primary strategy, and the one that has truly transformed transplant medicine, is immunosuppression of the host. This involves using a combination of drugs to dampen the recipient's immune system, preventing it from launching a full-scale attack on the new organ.
And what are the main tools used for this? I imagine it's a careful balancing act, given the side effects.
It is indeed a delicate balance. Historically, radiation, specifically X-irradiation, was one of the early methods used to broadly suppress the immune system, as it can suppress antibody formation and is toxic to rapidly replicating cells, including immune cells.
Right, but quite blunt.
Very blunt. Drugs are now the mainstay of therapy used in complex multi-drug regimens.
Okay.
Let's talk about some of the main classes. Corticosteroids, like prednisone, are powerful anti-inflammatory drugs that broadly deplete lymphocytes and suppress both T and B cell responsiveness. They are often a foundational part of immunosuppressive regimens, especially in the immediate post-transplant period and during acute rejection episodes. Then we have cytotoxic drugs, which include antimetabolites and alkylating agents. These inhibit DNA and RNA synthesis, thereby suppressing the rapid cell division and differentiation of immune cells. Examples include methotrexate, cyclophosphamide, and azathioprine.
Okay.
These effectively put the brakes on immune cell proliferation, preventing the expansion of reactive clones.
So they're basically hitting the immune system's growth. And what about more specific inhibitors like cyclosporin A and rapamycin? These sound like they're much more targeted.
They are, and they revolutionized transplant medicine in the 1980s. Cyclosporin A and rapamycin are calcineurin inhibitors and mTOR inhibitors, respectively. They are much more targeted because they specifically inhibit T cells by preventing crucial steps in their activation, such as cytokine transcription or signal transduction pathways.
Oh, more precise.
Much more precise. This means they suppress T cell function without broadly killing off all rapidly dividing cells, allowing for more selective immunosuppression and significantly improved graft survival rates compared to earlier broader agents.
Right.
Lastly, anti-lymphocyte serum, ALS, and monoclonal antibodies are designed to directly target circulating T lymphocytes, essentially depleting them from the body or blocking their function, primarily acting on cell-mediated immunity to prevent acute graft rejection, particularly during induction therapy or severe rejection episodes.
Beyond drugs, are there other, more advanced strategies, like trying to induce immunological tolerance? This sounds like the holy grail of transplantation, where the body completely accepts the new organ itself.
Inducing specific non-responsiveness to donor antigens without the need for lifelong global immunosuppression is indeed the holy grail, and it's a major area of active research. It's sometimes attempted in animal models by neonatal exposure to donor antigens, which can trick the developing immune system into accepting them as self. In humans, strategies are being explored, such as infusing donor bone marrow cells alongside the organ transplant to induce mixed chimerism, where the recipient's immune system coexists with some donor immune cells.
Interesting.
While challenging, achieving true tolerance would eliminate the side effects and risks associated with chronic immunosuppression.
And then there's the fascinating concept of immunologically privileged sites. This sounds like a natural loophole in the immune system.
Yes, it's a remarkable biological phenomenon. Certain sites in the body, such as the anterior chamber of the eye, the cornea, the brain, and the testes, are considered immunologically privileged.
Why is that?
They have unique characteristics. They typically lack lymphatic vessels and sometimes even blood vessels, which effectively sequesters them from the full force of the systemic immune system. This unique environment limits the access of immune cells and antigens, thus allowing grafts to be placed in these sites with significantly reduced risk of rejection. This explains, for example, why corneal transplants are often highly successful even with less rigorous matching.
So we've talked about the body rejecting the graft, but there's an inverse problem, isn't there? When the graft actually attacks the host. This is the graft versus host reaction, or GVHR, a significant concern, particularly in bone marrow transplantation.
This is a critical and potentially severe complication, a complete reversal of the usual rejection scenario, and it is indeed a major hurdle in hematopoietic stem cell transplantation, commonly known as bone marrow transplantation. GVHR occurs when an immunocompromised recipient receives a graft that contains immunocompetent T cells. In this scenario, it's the donor T cells, newly introduced into the recipient, that recognize the recipient's host's tissues as foreign and mount an immune attack against them, essentially seeing the recipient as an intruder.
So it's a full-blown assault by the new immune system on the patient's own body.
Yeah.
What are the specific conditions that are required for GVHR to occur? It sounds like a perfect storm.
It is a precise confluence of factors. 3 crucial components are required for GVHR to manifest. First, the donor graft must contain immunocompetent T cells, meaning they are mature and capable of initiating an immune response. Second, the recipient must possess transplantation antigens that are absent in the graft. Essentially, the donor T cells must find something truly foreign to react against in the host's body. And third, and critically, the recipient's immune system must be sufficiently impaired, for example, by pre-transplant irradiation or existing immunodeficiency, such that it cannot reject the graft itself. This impairment allows the donor T cells to survive, engraft, and then proliferate in the host, leading to the reaction.
This sounds like a major hurdle for something as life-saving as bone marrow transplantation. What kind of clinical features does GVHR present?
It absolutely is a major complication, affecting a significant percentage of bone marrow transplant patients and contributing to both morbidity and mortality. In full-blown cases, GVHR can manifest with a variety of severe symptoms affecting multiple organs. Common features include fever, a characteristic skin rash that can range from mild to severe, intense diarrhea, protein-losing enteropathy where the gut cannot absorb nutrients properly, and potentially even more systemic issues like hemolytic anemia, thrombocytopenia, and splenomegaly. In its severe forms, particularly in animal models, it's sometimes referred to as runt disease due to the profound wasting and developmental issues it can cause. It's a testament to the immune system's power, even when it's not our own.
So, given the severity of GVHR, how do medical teams try to prevent this devastating reaction? It must be a painstaking process.
Prevention strategies are paramount and involve meticulous planning and execution. These include careful HLA matching between donor and recipient to minimize antigenic differences.
Matching again.
Always important. A crucial approach is the removal of T cells from the donor bone marrow graft, a process called T cell depletion before transplantation, thereby eliminating the primary cells responsible for GVHR.
Okay, remove the attackers.
Right. However, this can also increase the risk of graft rejection and relapse of the underlying disease, so it's a balance. Other strategies include using frozen or irradiated blood products for the recipient, which helps to inactivate any residual donor lymphocytes. Post-transplant, specific immunosuppressants like anti-CD4 and anti-CD8 antibodies, which target residual T cells, can also be used as prophylaxis or treatment to mitigate the risk. It's a constant balancing act to prevent GVHR while ensuring the graft engrafts and fights off the underlying disease.
Wow, what an incredible journey we've been on today.
Indeed. We've navigated the complex and often precarious landscape of the immune system from its fundamental life-saving role in defending us to the profound challenges that arise when its intricate mechanisms break down in immunodeficiency and autoimmunity. And finally, we explored the extraordinary dance of acceptance and rejection that plays out in the fascinating world of transplantation, where medicine attempts to skillfully manipulate these powerful forces.
We truly hope this deep dive has given you a clearer, more nuanced understanding of these critical medical concepts. It's been a fascinating shortcut to being well-informed about the hidden battles within our bodies and the remarkable, often ingenious ways medical science intervenes to protect and repair us.
As we've explored the detailed mechanisms of the immune system, both in its surprising failures and in our increasingly sophisticated attempts to manipulate and redirect it, it truly makes you wonder. Given the body's incredible complexity and its innate powerful drive for self-preservation, what are the ethical and biological limits to our ability to repair, replace, and ultimately redefine what it means to be self in the context of advanced medical intervention?
That's a profound question to ponder, and one that will surely continue to evolve with medical breakthroughs. Thank you for joining us on this deep dive. Until next time, keep exploring, keep questioning, and stay curious.